Hello, good evening, everyone. Good evening, Dr. Yunus. My name is Elishua Ngina, and I'm presenting head injury along with Ayman Hanif and Kabir Hassan. And I'll be doing the history part, and we'll proceed. My colleagues will take over the rest of the presentation.
Wa alaikum salam. Please proceed.
Okay, so for this case, I'm presenting SC, a 46-year-old male who's a construction worker and stays in Kirinyaga. He was admitted to KNH on the 13th of February 2024, and his history was obtained as a corroborative history from his siblings. His chief complaint was fall from a height, and the patient was last well until 2 weeks ago when he fell from the second floor of a construction site. The mechanism of impact was actually he slipped and fell from the second floor, and he sustained a blunt head trauma on the left frontal aspect of his head, and he sustained injuries to his right leg. There was loss of consciousness immediately after the fall for an unknown duration, and it was not associated with seizures, autoria, or rhinorrhea. Patient did not had no history of vomiting the fall. Then the patient was taken to Kerugoya Hospital by his colleagues, where they applied a cast on his leg and then they gave him IV fluids, and he was immediately referred to KNH the following day for a neurosurgical review. And his GCS on presentation in KNH was 8 out of 15, and he was immediately taken into theater for craniotomy and elevation and evacuation of an acute epidural hematoma that they had found. He stayed in ICU for 7 days post-op, where his relatives claim that he started opening his eyes and blabbering on day 5 and couldn't recognize them. He couldn't speak properly, but he was just saying incomprehensible words. And the patient had no premorbid CNS symptoms prior to the fall. For his past medical history, this is his index admission. He has had no past surgeries or no blood transfusions. He has no known food or drug allergies, and he has no history of chronic illnesses. And in family social history, the patient lives with his wife and 3 children, and there's no chronic illnesses in his family, diabetes or hypertension or cancers. He does not smoke cigarettes or consume alcohol and has an NHIF cover. In review of systems, the patient had an open right tibial fracture and a cast was placed, but all other systems were unremarkable. So in summary, I'm presenting SC, a 46-year-old male who presented to KNH after a fall from a height 2 weeks ago and sustained a blunt head injury and an open right tibial fracture. And the head injury was associated with loss of consciousness for an unknown period of time and is being managed in KNH post-op. For
Assalamu alaikum.
examination, I would like to hand it over to Kabir. Thank you.
Assalamu alaikum, everyone. So, starting on examination, when we did the general examination, the patient was lying supine in bed. He was sick looking with an altered level of consciousness and confused. His neck was rotated to the right side, and upon trying to tell him to move it to himself, he was not moving it, and it was not moving very easily. He had a surgical scar extending from the middle of the frontal bone up to the left ear. He had a subconjunctival hemorrhage in his left eye, and he had a knee backslab on his right lower limb. He had no jaundice. He had conjunctival pallor. Cyanosis was not elicited as the patient did not open his mouth. There was no clubbing, no pedal edema, no lymphadenopathy. He was dehydrated and the patient was wasted. His vitals, his BP was 134/86, pulse was 87, rest rate was 16 breaths per minute, temperature was 36.4 degrees, and SpO2 levels was 96% on room air. Going to the CNS examination, on assessing the higher function, the patient had an altered level of consciousness. He was oriented in time, place, and person. He had a good long-term and a short-term memory. He had intelligence and his speech was coherent. On the GCS scoring, he had a total of 14 out of 15, with eye opening being 4, the verbal response was 4, and the motor was 6. On cranial nerves, the olfactory could not be elicited. On optic, it was intact. He could see color and he could read. On ophthalmic, it was intact. And basically, there was a bilateral reaction to light. The trochlea was intact. Abducens was intact. The trigeminal was not elicited as the patient was not cooperating. On facial, it was intact. Vestibulocochlear was also intact. The glossopharyngeal could not be elicited. The vagus also could not be elicited. The accessory was weak now, especially on the right side to which his neck was turned. The hypoglossal was not elicited. On motor function, the gait could not be assessed as the patient was in bed. For power, the upper limb was 4. The lower limb on the left-hand side, which was assessed, was also a 4. The tone was normal bilaterally in all the joints, the upper limb and the lower limb, the left-hand side of the lower limb. The reflexes, all upper limb and left lower limb reflexes were present. The Babinski sign was normal and there was no clonus. On sensory function, it was it was unable to properly assess due to the patient being uncooperative, and the cerebellar function also was unable to be assessed due to the patient being uncooperative and not being able to follow instructions accurately. The CVS examination, on inspection, there were no scars and the precordium was not hyperactive. On palpation, no thrills and no heaves were elicited. On auscultation, S1, S2 were heard. No murmurs could be heard. On the respiratory exam, inspection, there was symmetrical chest expansion with no scars. Palpation, the trachea felt central. On percussion, there was normal resonance. On auscultation, there was normal vesicular breath sounds heard across all the lung fields. On GIT exam, on inspection, the abdomen was moving with rest. Palpation, there was no tenderness noted and no organomegaly elicited. On percussion, it was tympanic. And the impression was a left frontal depressed skull fracture, a left frontal acute intracranial hemorrhage, and a right tibia fibula fracture. Differential diagnoses could be an epidural hematoma, acute subdural hematoma. So as of now, the diagnosis that we were working with was the left frontal open skull fracture and a left acute epidural hematoma and an open right tibial fracture. So when the patient arrived, the ATLS was done. On arrival, his GCS score was 8 out of 15. There were samples taken for investigation in the trauma series of chest X-ray, pelvic, fast C-spine, and the right tibia and fibula X-ray was carried out. On neurosurgical review, we had a head CT and a bone window taken. Investigations on admission, the HB was 11.9, the WBCs were 7.78, platelets were 207, UECs, urea was 9.52, the sodium was 144, potassium was 3.98, and creatinine was 83.2. So this was the C-spine X-ray. It was not much, there was nothing, there was no abnormality seen on this one. If we move to the next one, you can see that there is a fracture through the tibia on the right leg. And on this one, basically okay, thanks. On this one, we can basically see the formation of a lentiform type of a shape on the left aspect. And this was the 3D view of the head in which you can see the open skull fracture where it was depressed. On the bone window, there was, if you look at the second row, from the second last row, you can basically see the fracture in that area on the left-hand side, in the frontal left-hand side. So the definitive management was surgical management, craniotomy, elevation, and then we would evacuate the acute epidural hematoma. This was the BGA which was carried out post-op. There were no abnormalities. And that's the end of the history and examination. Hassan.
Okay, thank you for the good history and physical examination. Before I make my comments, does anyone on the call, does anyone have any question about this? We start with the history. Any questions on the history? Take us back to the history one more time, please. Okay, no question, anybody? You can just unmute yourself and ask. Well, can you guys hear me?
Yes, we can.
Hello?
Yes.
So I like the history. The history had no issue, but one, chief complaints need to have a duration. Yeah? Loss of consciousness since when? From the time patient came to her, or from the time the patient came to the hospital, or you need to tell us loss of consciousness. And when you talk about loss of consciousness, I will talk about this in a bit more detail later. But when you talk about loss of consciousness, you have to tell us what is inability to talk, inability to open his eye, inability to walk. Instead of loss of consciousness, actually, we like saying altered level of consciousness, because confusion is altered level of consciousness. A patient who is in coma, that is altered level of consciousness. So I think that is something to think about. And number two, a patient who has altered level of consciousness, I did not hear you talk about whether or not this patient has taken any drug of abuse. Is a patient intoxicated with alcohol? Has he taken anything else? Water poisoning? I think that is something important that needs to have come out. And then for us, surgical patients, we want to know if the patient is on any, although it's a young patient as you described, we want to know if the patient is on any drugs that will predispose patients to bleeding, like patients on aspirin, patient on clopidogrel. Anything like that is important to us. What else? I think the rest of the history, I had no big problem with it.
I have a question.
That was a good. Yes.
Why is it important to state the negative? There was no history of vomiting.
A good question. Or what do you say? No history of vomiting, no history of seizures, no history of otorrhea, rhinorrhea. Why we do that is that vomiting is a sign of increased intracranial pressure. It tells us how significant the injury to the brain is. When you have injuries to the brain with a very severely increased intracranial pressure that happens very rapidly, patient can convulse. Or if you have local lesion that is involving the cerebral cortex that irritates the brain, you can have convulsions. So convulsions, vomiting, those are signs of severe trauma to the brain. There is significant injury. Then we can go ahead and ask, why do we talk about otorrhea and rhinorrhea? Hello? Anyone? Why do we talk about otorrhea and rhinorrhea?
Is it to assess? Assalamu alaikum.
Wa alaikum salam, yes.
Sorry, is it to assess basis skull fractures?
Yes. When patients have otorrhea and rhinorrhea, what that tells you is that one, there is a dural tear that is leaking CSF. Two, that there is a tear in for example, temporal bones that is communicating with the middle ear, and also there is probably a tone middle ear. That is why all those things are happening when there is otorrhea, CSF otorrhea. When there is CSF rhinorrhea, it means there is a dural tear. There is a fracture in the frontal bones that are involving, or frontal, like frontal aspect of the face or piece of the skull that is involving the a tone air sinuses, the frontal sinus, the ethmoid sinus, the maxillary sinus. Any of those can give you rhinorrhea. So those are also a way to look at what are the other injuries we are seeing.
I also have another
Any more
question.
questions? Yes.
This is to the presenters. Why is the chief complaint loss of consciousness and not the fall? Because loss of consciousness was secondary to the fall.
I'd like to that. We had already made the document and sent it, and we couldn't edit it in 2 places. So the chief complaint is actually fall from a height and not loss of consciousness. It
Okay,
was a
thank
small mistake. Sorry about that.
It's okay. We can accept loss of consciousness. We like loss of consciousness. Fall from a height is not a neurosurgical problem, but loss of consciousness might be. You can fall from very high and then. But the only issue I have with it is where is the duration? Are we okay? Any more questions?
Assalamu alaikum. I have a
Wa alaikum
question.
salam.
Kudos to the team. That was a wonderful presentation. So, Doc, my question is it paramount that we inquire about the sample, the mnemonic sample in our HBI, or it comes in another place?
Thank you for that question. Yes, that is important. One, I think we need to understand that patient is not just a walking brain. You see, when a head injury is just brain and the bones around it, but the patient is everything else from head to toe. So the first person that comes into contact with this patient should actually, when you see this patient first, you need to do an ATLS protocol, A, B, C, D. You know those things. I don't think we need to belabor those points. And part of the history should be that sample. Sister, you can maybe tell us what sample stands for, so that just as a review, as most of us will be interns very soon.
Okay, so the sample history is taken for any patient who is in trauma. So it's a mnemonic, SAMPLE. So the S stands for symptoms. So the patient's chief complaints. The A is for allergies. If the patient has any allergy, non-allergy to drugs. Then the M is the medication. That's why Dr. Yunus was asking, we would have loved to know if the patient is on any drugs like aspirin and those things that predispose them to bleeding. So you ask, we take a good history on the medication the patient is on. Are they on over-the-counter drugs? Are they on any herbal drugs? Okay, and I'm sorry about that. Yeah, so you basically ask them about the medications they're on. So P is for past medical history. Is there any chronic condition that we should know that the patient has, or any relevant past medical history? The L is for the last oral intake because of risk of aspiration and those things. So it's always good you ask the patient, what was the last thing they took? And then E is for events leading up to the illness at that time. For example, our patient had loss of consciousness secondary to a fall from height. So we just explore around the events. That's now the sample history.
Thank you. That is detailed enough. Thank you so much, Sister Najma. I think proceed. Any questions on physical examination? Please take us to where you are taking these patients' Glasgow Coma Scale. Yeah, just this slide. You say patient has altered level of consciousness. He's oriented in place. He was oriented in time, place, person. Time, person, place. He has good long and short-term memory. He had intelligence. He had coherent speech. What is the GCS of this patient? From that, forget what is written down here. Yes? Kabir, patient who is oriented in place, person, and time, who has good short-term memory and long-term memory, who has good intelligence, who has coherent speech, what is the GCS of that patient?
It would be 15, doc. But okay, the slight concern was at some points in time, he would follow instructions. And then at other points in time, we just lose him completely. That's why there was some, like, for example, I could elicit power because at that point in time, he was following my instructions to a certain extent, like upon continuous repetition and insistence. But when we reached the point of, like, we were checking his cranial nerves, he was not very cooperative, even up to the point where we told him, like, to check for pallor in the mouth. He completely refused, like, to even try and open his mouth or do anything. So I was a little confused on that aspect of consciousness, because he was oriented, he'd give us good answers, but at the same time, he wasn't, like, fully listening.
Okay.
It wasn't because he was...
Oh, proceed, sorry.
Like, it wasn't because he was, like, irritated or something with us and was not following. It was just like, you could just, like, he'd lose himself for a few, then he'd come back, and then he'd lose himself. So it was like on and off. Hence, I decided to put all of them here, so maybe we could just, like, get a brief understanding on that.
When you say patient is well-oriented, in place, person, and time, patient knows where they are, patient knows who you are, patient knows what time it is. It means that patient can follow instructions. So this patient is not, if he had issues following instructions, that patient probably was not well-oriented. Because if he's well-oriented, in person, he knows you're a doctor, you know, whatever you're doing is you're trying to make him better, so he should follow instructions. So this patient might not be GCS, might be 14, but I have issue with you saying this patient has normal long-term and short-term memory and is well-oriented and has good intelligence and coherent speech. So, okay, move to the next slide. So, okay, from here, you are able to elicit optic, intact, you could see color, ophthalmic. Okay, the third nerve is called oculomotor, not ophthalmic. Hello?
Yes.
The third nerve is called yeah, it's called oculomotor.
Oculomotor. It is.
And then how do you test for cranial nerve 3, 4, and 6?
So you would draw the letter H.
Okay.
While, like, for the right hand side, we're using your right hand and the left hand side, like the opposite of the patient.
So you do extraocular muscle movement is what you're trying to say?
Yes.
So that they're able to move their eyes in all the 6. So those ones you check together when you're examining.
Yes.
And then trigeminal, how do you... Trigeminal is cranial nerve 5, not 6.
Yes, it's a slight error here. Sorry about that. So trigeminal, basically trigeminal has two things. It has a sensory component and a motor component. So for the sensory component, we'll check the V1, V2, V3.
Okay.
And for the motor, we'll tell the patient to basically clench their jaw and assess the masseter.
Okay. Things, what about the sensation of the anterior 2/3 of the tongue? Which nerve is that? Like sensation, feeling pain.
I'm
How
not
about
sure about pain taste.
how about what is this? How about sensation on the cornea?
Okay, I
Hello.
didn't get that one.
Hello?
Yes, doc. Yeah, I wanted to say that I think the trigeminal has three orientation. You have the or deserved supply three routes. So you have the maxillary, you have the ophthalmic, and you have the zygomatic. So yeah, basically those are the three areas we should check for the trigeminal.
Okay, I thought it was V1, which is ophthalmic, V2, which is maxillary, and V3. But for you at your level, you have to test the sensation of the face. You have to test the cornea. You have to test the muscles of mastication. You have to take test the TMJ, temporomandibular joint, the jaw.
Yes.
Sawa. And then pharyngeal and vagus, you could not even, that patient cannot swallow.
So because his neck was turned in a certain position, it was very difficult, like
to elicit.
Yeah.
But
Like
the patient was talking to you. That patient was talking to you. Is a vagus that patient abnormal or normal?
I think it would be, I'm not sure. It would be normal though, because he could talk, so that means
he could talk. So his vocal cords are working. His the soft palate is working. Also, his tongue. He was talking to you probably. I don't know. Maybe. I don't think this guy had glossopharyngeal vagus problems. But anyway, sawa. If you say you could not assess, I have no problem with that. Next. Next slide, please. Why is this patient having power of 4 on the left or on the up? Is it this power of 4? Upper limbs, all the two upper limbs have power of 4, or is it just one?
From what we could elicit, it was like both of them, like both the right and the left upper limbs were giving us a power of 4.
Okay. Why though? Doesn't make sense, eh? Because if the patient had epidural on one side, was the epidural on the right or on the left?
It was on the left-hand side.
So if it is on the left-hand side, which side, which lower limb should have a problem? Yes?
Right. The right.
Should have been right, eh? So if this patient has both upper and lower limb problems bilaterally, what is the next thing you want to do? Let me ask a very pedestrian question. Bilateral upper and lower limb weakness. Anyone else can just chip in? Hello? Kabir? Bilateral upper and lower limb weakness?
So maybe it could be a lesion.
Thinking maybe spinal lesion.
Yes, spinal lesion, but what level of the spine?
C-spine.
This patient fell from up. So you expect he might have a spinal injury, but when a lesion is involving both upper and lower limb, as a few people are saying, C-spine should be think about. So I think we are okay with that. Yes, it is C-spine. A few people are saying it. Thank you. Then next. Hello. So okay, sawa. So I think these are the 4 slides that I wanted us to talk about. To know cranial nerve examinations, that is important. You need to you need to know how to examine the higher centers, the orientation, the at least GCS orientation, intelligence, abstraction, little things you need to. There is something called COMIS, the 5 things you need to go and have a look. I think that suffices. We are short of time. We have about, I think, 15 to 20 minutes. We can go to the next part of the presentation.
Doc, just
any more questions before I proceed?
One question, sorry.
Yes.
When you're assessing the high function,
yes,
the aspect of orientation, would it, like, when you're assessing GCS, orientation is part of it, would that be like repetition when you're doing GCS and then at the same time reporting orientation in different parts? I would just tie them together.
Anyone to respond? The component of the GCS. Hello?
Yes.
The component of GCS. Orientation is not part of the GCS. Even people with, as long as they're able to talk, their friends, or people who are in person, but they are. So your GCS, but that doesn't mean that GCS is part of orientation. Orientation in time, place, and person. Like, for example, someone knowing what time it is to go to 14. Usually have GCS, or have to have no orientation for you to have 15. So I think that is my answer. Any? You guys cannot hear me?
I can hear you.
We can hear you, Doc, but you are breaking slightly.
Oh. My internet doesn't seem to be bad. Any more questions? Can you people hear me now?
Yes, we can, Doc. You can proceed.
So next, or you guys have finished? Or is there a new presentation coming?
Yeah, this is the second presentation.
Please proceed.
Okay. So my name is Ayman, and I'll be taking you through the second part of the presentation on the discussion on head injury. So for definition, we have head trauma and head injury. Head trauma is just trauma to the scalp, skull, or brain, but head injury is trauma to the head associated with neurological deficits or change in the level of consciousness. So for etiology, we can have 2 types. We can have a blunt head injury, which is more severe, and then we can have penetrative head injury. Sorry about that. Even though penetrative looks more intense, the blunt head injury is more severe. So from the picture, we can see for the blunt head injury, you can see that there are 3 types of mechanisms of injury that can give you a blunt head injury. So on the left-hand side, you can have something known as a compressive force. In the second picture, you can have something known as accelerative force. And the third one is a decelerative force, or you can have a mixture of the 3. So we can talk about blunt head trauma. For blunt head trauma, you have scalp injuries and you have skull fractures. In scalp injuries, you can have scalp lacerations, scalp abrasions, and scalp hematomas,
also known as cephalohematomas. For the skull fractures, you can have a fracture at the vault or the base of the skull. The fracture can be open or closed, and it can be a coup or contre-coup. So for the scalp injuries, we can see on the left side, that's a scalp laceration. And on the right side, that's a cephalohematoma. So a cephalohematoma is a collection of blood between the periosteum of and the skull bone. So for the cephalohematoma, you should not stick a needle in it. So you shouldn't try to drain it because you risk forming an abscess. So for skull fracture, like I said, it can be coup or contre-coup. That means when it's coup, there's a direct impact on the skull, which causes a fracture. And since the skull is a round structure, forces go around it and it can go to the opposite end, causing a fracture in the opposite end of where the impact happens. So that's known as contre-coup. So the vault fractures can be linear, depressed, or comminuted. In the first picture, we can see a linear skull fracture. There are quite a few. And in the second picture, this is actually from our patient that we just presented. He had a depressed skull fracture, which you can see from the bone window. So just a little bit about basilar skull fractures. Doc had already explained it during the Q&A. So the base of the skull is divided into three. You have the anterior, middle, and posterior fossa. So when you have a fracture in the anterior aspect, that is the frontal bone, that's where you see the classic raccoon eyes, which you can see over here to the right of the screen. And you get rhinorrhea, as Doc explained how that happens. When you have vault fracture in the, basal skull fracture in the middle, so that's like the temporal bone. So that's where you can get the battle sign, which can be seen in the second picture below. It's behind the ear. And you can also have otorrhea. So just a little bit about something known as the halo test. So when usually patients will be bleeding from the nose or the ear and you don't know if that contains CSF. So what you can do is you can take a sample of the blood and blot it on like a filter paper or a paper towel. And if CSF is included, the CSF will usually separate from the blood, giving you this distinct lighter ring around the dark blood area. And this is known as the halo sign, which is positive when there's a CSF leak. So what I explained are all primary brain injuries. What can happen after that, like minutes or days after the primary injury, is something known as secondary brain injury. So I'll take you through that. So 5 types. So the first one is intracranial hematomas. So these are things that, when we go to the wards or the A&E or the theaters, this is like the things that we've seen. So one type of the 3 types of intracranial hematomas. You have the epidural hematoma, you have the acute subdural hematoma, and chronic subdural hematoma. So in your epidural hematoma, this is a blood leaking and accumulating between the skull and the dura. It's usually due to laceration of the middle meningeal artery, but about 10% of it can be venous origin. So on a CT, you will see it as a biconvex hyperdense lesion or lentiform. So this imaging is actually from the patient we just presented. We can see that he has a epidural hematoma on the left side of his skull. So the second type is acute subdural hematoma. Why is it acute? Because the symptoms show up within 3 days. It's associated with diffuse brain injury, and it's more intense because the subdural space is a real space compared to the epidural, which is not a real space. So that's why when you get these subdural hematomas, you have to act like really quickly. So on your CT, you're going to see it as a hyperdense crescentic lesion. So crescentic because it's a real space, so the blood can spread out, and hyperdense because so when hyperdense means acute, it's fresh blood. So that's how it presents on the CT. The chronic subdural hematoma. So these are more common in alcoholics and age of people more than 50 years, but there are other places that say 65 years. So usually the patients present with increasing daily headache, fluctuating drowsiness or confusion, or they have mild to moderate hemiparesis. So it's chronic because the symptoms show up 21 or more days after the trauma. So you can see in this CT, it's hypodense compared to the brain. This is because now the cells are dead. So this is how it would present on CT. So we have something known as subacute. Subacute is basically between 4 to 20 days. Okay, so that was the first secondary brain injury, which was intracranial hematomas. Another type of secondary brain injury you can get is cerebral edema. Now, cerebral edema also 3 types. You can have hypoxic. So in hypoxic, what happens is you have a decreased blood supply to your brain. Decreased blood supply means less oxygen. And your sodium potassium ATPase pump needs oxygen. You see, we need to produce you need oxygen to produce ATP. So when ATP is not being produced, the sodium potassium pump is not working. So what happens is sodium is not able to be let out of the cell, so it accumulates inside the cell. And we know that sodium attracts water. So the sodium accumulation will attract water, leading to cerebral edema. The second type is interstitial. There's impaired absorption of CSF, which leads to increased transependymal CSF flow, causing acute hydrocephalus. And the third type is vasogenic. So over here you have breakdown of the blood-brain barrier. So the proteins can enter the interstitial space, and this will lead to edema. So the third type of secondary brain injury, you have increased intracranial pressure. So we know the Monroe-Kelly doctrine. So the CNS contains the brain, CSF, and blood in a closed space. So increasing any one of these components will increase the pressure, and you will have a decreased volume of the other components. So now we know that normal intracranial pressure is about 7 to 15 millimeter of mercury, and the normal cerebral perfusion pressure is usually calculated by subtracting the like mean arterial pressure, you subtract the intracranial pressure. And you want it to be more than 60 millimeter of mercury to have a normal cerebral perfusion. In cases of, let's say, hematomas, when you have increased cranial pressure, so what happens if the intracranial pressure increases and the mean arterial pressure remains constant, the normal cerebral perfusion pressure will decrease, so the oxygenation of the brain is not happening very well. So to counteract that, the mean arterial pressure will also start increasing. And how does this happen? So you have your heart rate increases, you have increased contractility of the heart, and you have increased peripheral resistance. So this is all to increase BP and cause more blood to enter the brain. But this abnormally raised BP are detected by the baroreceptors, and so they will try to decrease it by triggering the parasympathetic response via the vagus nerve. And there's also direct distortion of the vagus nerve due to the raised ICP. That's why all this will cause a decrease in heart rate, which shows us bradycardia. And obviously, the body is also trying to decrease the BP, so you get widened pulse pressure. Then we have the brainstem that is also being distorted and compressed, and the brainstem is responsible for your breathing. So that's why you get the chain Stokes breathing. So when you have these three, the widened pulse pressure, chain Stokes breathing, and bradycardia, this is known as a Cushing's triad. So these are one of the symptoms you'll see in increased intracranial pressure. The other things you'll see is altered level of consciousness, the patient will complain of a headache, they'll be having vomiting, they could also be having like psychiatric symptoms like irritability, just to name a few. So the other secondary brain injuries you can have also infections and CSF leak. So how do these patients present? What are the clinical features? So the patient will have a history of trauma. So in our case, the patient had a fall from the second floor. So the etiology is usually, is it an RTA? Is it an assault, fall? So our patient had a fall. So details of exact mechanism. So unfortunately, the patient was not very responsive, and we had a corroborate history from his family that was not there during his accident, since he was at work at that time. So we couldn't get an exact mechanism of how he fell, like, or what part did he fall on, or anything associated with his fall, except for the fact that he slipped from the second floor and he fell down. So then you have the site of trauma, any wounds. Now, usually for evidence of head injury, you're looking for 5 things. So you have headache. Now you're concerned when there's an increase in severity. It's worse when changing position during Valsalva's maneuver, or it's worse early in the morning. It's associated with eye signs, vomiting, or seizures. Then the second one is seizures. Doc also explained that during Q&A. There is altered level of consciousness. Then you also ask for post-traumatic amnesia and neurological deficit. So for the initial management, when you have a trauma patient come, the first thing you want to do is execute your ATLS protocol. So you start with the primary survey. You make sure your airway is patent. If not, act. Check for your breathing. The GCS is below 8. In this case, the patient's GCS was 8 or 8 or below, so you need to intubate. Check for circulation. Then you check for disability, so you check the GCS score. Then your environment and exposure. So you want to expose the patient to see if they have any other injuries. So in this case, our patient had a right tibial fracture. Now the adjuncts to primary include the trauma X-ray in order for the patient. So just a little something about GCS. So when the patient came, his GCS was actually 8, and said any GCS 8 and below you want to intubate. So this is how you check for GCS. It has the eye-opening component, verbal response, and motor response. Eye-opening is out of 4, verbal is out of 5, and motor is out of 6. The lowest score you can have is 3, and the highest score you can have is 5, unless obviously in situations if the patient is intubated, so you can't assess. So for mild head injury, the GCS is 13 to 15. You can manage these patients as outpatients and you give them proper instructions. Moderate GCS is 9 to 12. For these patients, you have to admit them in the ward or HDU. And patients, severe GCS are between 3 and 8. And for these patients, you want to admit them in the ICU. So once you're done with your primary survey, you move on to your secondary survey, which includes the head-to-toe exam and the ample history, which is the allergies, medications, past medical history of pregnancy, last meal, and the event or environment that led to the injury. And then you have your lab samples taken. So for investigation, you want to do your blood work like full blood count, UECs, and GSM. This is so in case you want to operate, like this is for operating purposes. Then you also want to do imaging for the head injury. So the gold standard you do is a non-contrast CT scan of the head to check for any of these, like, you can diagnose your epidural hematomas from it or your acute subdural hematomas. So that's what you want to do. So for management, so your aim is to prevent the secondary brain injury because the primary has already happened. So except for the surgical interventions, the medical ones include you want to elevate the patient's head. So when you elevate the head, it promotes the venous drainage from the head. So when you promote venous drainage from the head, the amount of blood reduces, and this will decrease ICP according to the monotony and hypercapnia that increases ICP. So you want to give the patient mannitol. So the dose is 0.25 to 1 gram per kilogram by intermittent bolus infusion every 4 to 6 hours for 2 days. You don't give it for more than 2 days because they get refractory cerebral edema. Now you can hyperventilate the patient, but this is only done in ICU. You can't tell a patient to hyperventilate themselves. This is mechanically done. You give the patient anticonvulsant therapy. In this case, you want to give phenytoin. So what happens is when a patient they have seizures, there's increased blood flow to the brain, and increased blood flow means like the one compartment is increasing, which causes increased ICP. So when you give phenytoin, you're preventing these seizures from happening. Now, you don't give GABA potentiating anticonvulsants like gabapentin because these depress the CNS. Then you have a head injury chart. This is for monitoring purposes to prevent mortality. So what happens if you have a head injury chart, you know, okay, I have to monitor the patient every half an hour. Others, you know, 4 hours can go by and you don't monitor, and when you come back, you find the patient was if you're giving them tramadol decreases seizure threshold, so you need to give it with an anti-seizure. Now, sedatives is something that you only give in ICU. So you give a high dose diazepam, but this is only in ICU if the patients have cranial hypertension refractory to medical and surgical therapy. Yeah, that's the end of my presentation. I just want to thank someone for giving us this opportunity. Yeah, back to you.
Thank you, mashallah. That's a wonderful, elaborate presentation. Just a few points. One, in terms of increased intracranial pressure, don't expect to meet every patient you meet to have Cushing's triad. By the time patient has Cushing's triad, that patient is almost already dead. And Cushing's triad is a rare thing, so don't look for it. In most of the patients, you will not find it there. Two, in terms of medications, yes, we don't give diazepam anymore, I think. If the patient has increased intracranial pressure that is refractory to other many treatments that I think is beyond the scope of this, we usually put them in something called barbiturate coma. We give them we give them pentobarbital or sodium thiopental to knock them out so that their cerebral metabolic rate reduces. The other things that you mentioned, I think we need to emphasize that these questions will come in your exam, that in head injury, the most important imaging investigation is non-contrast head CT scanner. That is an important thing. Another thing is in patients who have GCS or Glasgow Coma scale less than 8, or the other important thing that I think we need to talk about is in patient who has increased intracranial pressure, or in patient who has head injury that has depressed level of consciousness, when do we say we need to image their spine, or what do you do with about their C-spine? Or anybody? Do we image their spine? This one, someone has to talk. Can you guys hear me? Hello?
Yes, we can.
We are starting with the presenter because you presented very well. Yes, when do we say let's image the spine?
So for C-spine X-ray, it's actually an adjunct to the primary survey. It's one of the trauma series. I think it's very important to assess that. Yeah.
Okay. So we've agreed we're doing C-spine X-ray. What are the views?
You want to do a lateral C-spine X-ray?
Lateral. What else do you want to do?
You also do an open mouth.
An open mouth. What do we call that view? What do you want to see when you're looking at the open mouth?
The C1, C2.
Yes, you want to see the odontoid. That's the important thing. So it's called odontoid view. And then why don't you do an AP also? So AP, lateral, and odontoid view. Those are the things to do. Next question. If we did 100 patients, if we did an X-ray in 100 patients that has C-spine injury, how many of them can be picked by an X-ray? C-spine X-ray. The answer is about 53%. So X-ray or C-spine X-ray actually misses 47% of significant C-spine injury. So what does that tell you? Is that efficient? See, 53 to 47 is almost half. So it's like tossing a coin. Eh? So for patients who have injury, patients who have depressed level of consciousness, GCS of even less than 12, we always ask CT, C-spine. The Kabir presented a CT, C-spine. Eh? So that is important that in patients where you do, patients especially with moderate and severe head injury, when you ask for head CT, you also ask for CT, C-spine. And I think, I don't know whether we went through, but there are usually ways to read those X-rays. And then we did not have a lot of time, but Kabir just said, this one looks okay. He moved, they said head CT, there's an epidural hematoma, he moved. There is more to that. Eh? There are something called ABCs, those alignment, bone. What does I think? It's supposed to be ABCD. We can have another session where we just talk about C-spine if you guys want or you get that time. But this is a very wonderfully prepared presentation. I have a few slides. I don't know whether we can go through. We're already past our time. So I don't know. Can we go through those slides or we can call it a night because the presentation has already been very well.
I think we can go.
Yes.
We can do it. We can go.
There are not many. I promise I will. Hello?
Yes, we can
Yes,
see.
we can look.
Yes.
Okay, so just a few slides. I have no disclosures. So when you talk about head injury, I think most of the things have been gone through, but head injury is classified into mild, minimal, mild, moderate, and severe. You need to know this. If patient has GCS of 15, has not had loss of consciousness, has no amnesia, whatever other injury he has, that is usually minimal head injury. But if patient has GCS of 14 and also has a brief loss of consciousness that's less than 5 minutes, or impaired alertness or impaired memory, then we say this patient has mild head injury. So moderate head injury is any patient who has injury more than 5 minutes, loss of consciousness more than 5 minutes, has significant focal neurologic deficits, has GCS between 9 and 13. So then severe head injury is GCS between 3 and 8, but GCS between 3 and 4 is critical head injury because that patient is almost on his way upstairs. So in terms of history, the important things, is that you have to make, this one has already been gone through, mechanism of injury, altered mental status, whichever it is, if there is seizure, if there is confusion, if there is apparently only host can share in a meeting.
You can share now.
Okay.
Okay.
You can see my screen now? Hello?
Yes, we can.
And you can hear me also?
Yes, we can.
Okay, thank you. So, where did I stop being audible? Hello?
From the first slide.
From the first slide?
Yes.
Hey, that is it. Okay.
We were talking about the history part, the mechanism and
the history
yes.
part, huh?
Yes.
But you can hear me now, huh?
Very well,
Okay,
yes.
so I will say, yeah, sorry. So I was saying, in terms of history, the things not to miss is altered mental status, seizures, confusion, amnesia, focal neurologic deficits, otorrhea, rhinorrhea, and any related injuries that we have talked about. This part we have already talked about. I think I'll just jump. Can you hear can you see my screen now, and can you hear me?
Yes, we can, Doc.
Okay, so in terms of physical exam, you have to palpate this patient's facial bones. You have to the frontal bone, the maxilla, the orbital rim, the mandible. You have to palpate because this patient can have facial fractures. Auscultate also the carotids because this patient can have carotid dissection. They can have carotid transection. Palpate the globe of the eye, auscultate the globe of the eye because this patient can have. This patient can also have a carotid cavernous fistula where the cavernous sinus is communicating with the carotid such that the blood comes back. The patient has this pulsatile ecchymosis. Examine the spine, look for deformities, look for bruising, look for tenderness, and all those things are important. Is everybody on the slide of the CNS exams?
Yes,
Hello?
we are, Doc.
Okay. So on the cranial nerve exams, you have to check for vision of this patient. Fundoscopy is important because it will show us increased intracranial pressure. It can all because increased intracranial pressure will show us papilledema. Also, it's important to look at the retina because if there is very severely increased intracranial pressure, this patient can get retinal hemorrhages. It's called Tasson syndrome. Then there is something called relative afferent pupillary defects or RAPD. This one shows if the patient has optic nerve injury, you can tell which side has a problem. Also, you have to, on cranial nerve 3, you have to check for something called anisocoria. Anisocoria means unequal pupil. If you look at the image on the top, you can see normal pupils. If you look at this, if you look at patient, the lower image, you could see the eye on the right is larger than the left. So you have to also check for facial asymmetry. Quick question, patient who has anisocoria on the right, where is that lesion? Anybody? Hello? Patient with anisocoria, anisocoria usually localized to the same side, because if you have anisocoria, it means you have third nerve palsy on that side. And third nerve palsy in head injury most of the time comes from something called ankle herniation. We will talk about that in a minute, just slightly. In terms of examination, you have to check the GCS, you have to check the motor, you have to check the sensor. I think this one has been very well covered. I would not want to belabor that. From examination of the patient, features that tells us that this patient has increased intracranial pressure is pupillary dilatation, whether it is unilateral or bilateral. If there is pupillary asymmetry, that is if there is anisocoria, or if there is a decerebrate or decorticate posturing. You have to know the difference between decerebrate and the decorticate posturing. I think this image just shows you. Another question, is the decerebrate or decorticate, which one is worse? Hello? Can you guys hear me?
Yes,
Hello?
we can hear you.
Yeah, between decerebrate and decorticate, which is worse?
Decerebrate.
Eh? Decerebrate, yeah, that's right. But why? I'm taking you to, you are looking at the slides for CNS, eh? So what is motor of 3, by the way? That is decorticate, abnormal flexion. If you see the patient decorticate, they are abnormally flexing. So abnormal flexion is 3, while decorticate is abnormal extension. So that is worse. So in patients who has head injury, you don't do head CT in everybody, eh? So you only do head CT in patients who has these features, eh? Patient who has history of loss of consciousness or post-traumatic amnesia, if there is associated headache, if there is vomiting, if there is age more than 60, or if the patient is intoxicated with alcohol, or if the patient has short-term memory deficits, or if there are signs of trauma above the clavicle, like if the patient has raccoon eyes, if the patient has battle sign, or if patient had an episode of seizure, or if the GCS has fallen less than 15, or there is specific focal neurologic deficits, then you need to do a head CT scan. Or patient who has been on blood thinners, like patient on anticoagulants or antiplatelets, if the GCS, even if there is some element of loss of consciousness, even if GCS is 15 now, you need to do a head CT scan. Then when you talk about focal neurologic deficit, the stuff we see in head trauma is that, one, patient can have aphasia, inability to talk. That is a focal neurologic deficit. Patient can have one-sided weakness. That is a focal neurologic deficit. Patient can have anisocoria. That is a focal neurologic deficit. Patient can be confused. Confusion is focal neurologic deficit. So any of those, you are supposed to do a head CT scan. So in the rest of the people who do not have any of this, you should not. Then the other thing I wanted us to go through is a normal head CT scan. This is a normal head CT scan. Is a long thing. I do not want us to go through this. The thing that I want us to go through, everybody see my screen? Hello?
Yes, we can, Doc.
Yes.
When you are looking at a head CT scan of patient with head injury, these are the 3 things I want you to look. Are we everybody there, please? Even if you have been sleeping, please wake up. Now we have gotten to the interesting part. One, if you look at this part, the first image, are you guys seeing my cursor?
Yes.
Is my cursor visible on the screen?
Yes.
You can see that is the foramen magnum, the bony part, and then this anterior part, that is the medulla oblongata. These are on the sides. This one are called cerebellar tonsils. Don't look at those. I don't want you to look at those. What I want you to look for when you are looking at the foramen magnum is this dark thing. This dark thing is the CSF space. The dark here, the dark here, the dark here. If those dark things are still there, what that tells you is that this patient has not had foramen magnum herniation or tonsillar herniation. So this patient has not coned. So increase intracranial pressure is not there. It's not so bad is what I'm saying. Go to this other image. There is something important I want you to look. You can see this central part, this thing at the center of the brain. Anybody, are you seeing me? Are you seeing where my cursor is?
Yes.
What structure is that?
Ventricles.
Ventricles. Any other thoughts? Ventricles, I don't agree. Yeah, the ventricles. I don't agree with you. Anybody else?
Or thalamus.
Thalamus is just up. Anyone else?
Is it the midbrain?
Does it
Midbrain.
Who said midbrain?
Boxer.
Oh, I agree with you. That is midbrain. Thank you so much. So midbrain is called mesencephalon. You remember that embryology? And around the mesencephalon, there is this dark thing. Don't even look at the midbrain. Just reach where it is, but look for this dark thing. This dark thing are called basal cisterns. These are CSF spaces. If I want to complicate your life, this anterior to it, these are the crus cerebri. So these are called crural cisterns up here. If you just go up here, this is the pituitary is just down here. This is called suprasellar cistern. I do not want to take you there. Come on this side. This is called ambient cistern. Anterior, posterior here at the back, there are these two things that looks like these two protrusions. Those are called quadrigemina, the superior collicular. These are called quadrigeminal cisterns. So all these cisterns put together, they are called perimesencephalic cisterns. Hata usiseme perimesencephalic cistern, forget about those. But you come to the midbrain, ensure that the dark CSF space around it is there. Tuko pamoja? Hello, everybody? Hello?
Yes, we are together, Doc.
Yes.
Nice. Okay. Then come to the lowest image. What big structures are these two things?
Lateral.
Hello?
The ventricles.
Whoever said lateral, whoever said ventricles, this is your time. These are ventricles, huh? They are symmetrically there. If you look at this brain, if you draw a line from posterior to the anterior, you can almost say the right side is almost the same as the left side, huh? Are we there? Someone, you guys need to be responding.
Yes,
then if you look at around the edges, you can see there is these dark spaces, the sulci and the gyra. You can see those are there.
Yeah.
We have finished looking at this. Is a normal brain image. One, because the foramen magnum is symmetrical in the midline. You can see the sulci and gyri are there. We are done. We just need to tell me those. That is a normal CT of the head, especially in patients who have traumatic brain injury. Now let's go to the deep waters. When you talk about traumatic brain injury, there is increased intracranial pressure. And that one has been explained very well by our last presenter. And when you have increased intracranial pressure, the brain starts looking for space. So if, for example, you are looking at this image here, you can see that there is some epidural hematoma there. And this epidural hematoma is pushing this right side, the side with the hematoma towards the side without. What will you see? One, some part of the brain can come below up here is falx cerebri. So below the falx. So this is called subfalcine herniation. And then down here, this is the anchors. So some of the brain can come below the anchors. It comes into almost joining the cerebellum here. You see the upper part of this upper part is called supratentorial because there is tentorium cerebelli separating. But there is a small space, a small opening in the tentorium that is called tentorial notch. This thing will come through the notch. So that is called ankle herniation. And then if there is the space if the space in the cranium is so much limited, it tries to come out through the foramen magnum. So you start getting something called tonsillar herniation. So herniation syndromes, you guys will be asked. So cingulate herniation or something called subfalcine herniation is where the one of the cingulate cortex passes through the falx cerebri to move to the other side. There is another one where one of the hypothalamus moves to the other side. It's called central herniation. That is, I think. So the types of herniations are cingulate herniation, central herniation. Those are the things to remember. Are we there? Hello?
Yes, we are.
Yes, yeah.
Then if you're looking at my screen now, look at these small images on the side now. This was the image we are looking at previously. You could see the CSF spaces around the medulla at the foramen magnum. If you're looking on this side, what are you seeing on the image where I'm pointing? Are you seeing the foramen magnum? Hello?
No, it's obstructed.
Eh? The foramen magnum is there. The foramen magnum is this bone. No, you cannot.
Nope.
Can you? Are we following this thing together?
Yes, we are,
Yes.
Doc.
You guys, are you there?
Yes.
Thank you. Next, the image below, if you look at it, the basal cisterns are open. Look at this image on that side. It's almost at the same level, but you cannot see the basal cistern. So these images, this first image tell you there is a very high increase in intracranial pressure, the lower one. And then come to the last image down. You remember this is the exact image we were looking at. You can see the brain is symmetrical. The lateral ventricles are symmetrical. You could see sulci and gyri. Look at the image on the side. What disease is this? Hello? Hello? What's the diagnosis here? Somebody?
Tuberculoma.
Hey, who is saying tuberculoma? You can see this. You can see the lentiform shape, the lentiform shape lesion. Or are we not looking at the same lesion? So there is that.
That's a subdural
hematoma.
hematoma.
Thank you. That is subdural hematoma. But forget about that. But if you look, if you draw a line from the posterior most to the anterior most, you realize this brain is not symmetrical. Such that that right side, this side has moved to the contralateral side. Then if you look at the lateral ventricle on the left, you are able to see the lateral ventricle, but on the right you cannot, because there is this hematoma that is compressing, so the brain is pushed to that side. So what we are expecting here is there is subfalcine herniation. Are we together there? I think if we finished these slides, we have finished all the hard parts. Lastly, you can see this is the same old slide we've looked at. You could see the brain is symmetrical. You could see the sulci and gyri are still there. But if you look at this, the image on the other side with cerebral edema, you could see that the brain is still symmetrical, but the sulci and gyri are effaced because the brain here is swollen. The brain is swollen. Lastly, these ones we have already talked about. One, epidural hematoma has been well discussed. Subdural hematoma has been well discussed. Skull fractures have been discussed. Something that have not been discussed is this lower layer. One, the image on the low, these two images, you could see that there are these white or hyperdense spots, and these ones are called cerebral contusions. Contusion means there are bruises in the brain. And then this image in the middle, if you realize, we are almost again at the basal cisterns, but these basal cisterns are full of blood. You see this white thing around it. So this blood is not in the brain, it is in the subarachnoid space. So this is called subarachnoid hemorrhage. Are we together? Subarachnoid hemorrhage is something that can happen when you have increased intracranial, when you have a traumatic brain injury. Then lastly, you can have an almost normal CT head with this small punctate hemorrhage at gray. I've already gone through that. Lastly, management depends on how bad or how severe it is. Observation, some of these guys with mild head injury, you can observe them at home. And this one you will go through at your own time because we have to go on way beyond our time. In moderate head injury, we have already been told, elevate the head to 30 degrees, you give analgesics, anticonvulsants, omeprazole, ondansetron, mannitol. Then you do repeat head CT. The important thing is if the patient develops new deficits or the GCS falls by 2 points, then you have to repeat HCT in any patient with head injury. Finally, I have a question. Why are we giving this patient omeprazole and why are we giving this patient ondansetron? One person, I think that will be the last thing we talk about. Hello?
Yeah.
Can you guys hear me? Hello?
Yes, we can hear you. Yes, Doc. The reason why we give omeprazole is to prophylaxis for stress ulcers. You know, these patients have undergone, it's like a traumatic event. They've gone through so much hell. So we just want to prevent stress ulcers. That's why we give omeprazole. For the ondansetron, I think it's we can tie it together. It's also, I think that because of their traumatic brain injury, the area post-trauma could be, activated a lot. So they'll have that nausea. So we want to prevent that as well.
Thank you so much. I agree with all those. What type of ulcers do patients with head injury get usually?
Cushing ulcers.
It has. Thank you. Cushing's ulcers. Ondansetron we give because one, as you said, these patients are they are predisposed to vomiting. Also, vomiting increases intracranial pressure. That is, with vomiting, you increase Valsalva. Valsalva means increased venous return, and therefore it's important. Anticonvulsants, for how long do we give in patients with head injury? Only 1 week. And the anti-analgesics, anticonvulsants we give is usually levetiracetam, or we know it as Keppra, or phenytoin. We don't usually give diazepam, valproate can be given, but we don't like it. The ones where there is a good evidence of efficacy is just phenytoin, levetiracetam. What else did I want to say here? Yes, these are some of the things you can check frequently, their neurologic status. And also these patients should be given DVT prophylaxis. You should put these guys usually on compression stockings. After 72 hours of surgery, even you can start them on like Clexane or something. For severe traumatic brain injury, that is GCS less than 8, always admit to ICU, intubate, ICP monitoring, evacuate any offending lesion if it is tenable. I think those are all I had, and thank you for listening to me. I can take any questions. Hello?
Thank you, Dr. Yunus. Thank you so much for the comprehensive presentation. So I have a couple of questions. So the first question is, what is the choice of analgesia in traumatic brain injury, especially patients with moderate and severe? Do you go immediately for opioids or you just go with the WHO ladder?
Thank you. Maybe I collect the question. So you said you had a couple of questions. That is one, yes?
Yes. So that's the first question. The second question is, patients who come with GCS of, let's say, 5, okay, that's severe traumatic brain injury. But let's even put 4, say a GCS of 4. Do you still, because the chances of surviving, it's very low for that kind of patient. So do you still go through with all this, take them to if they have, for example, a hematoma, you still take them to the theater and then do the craniotomy and evacuation, or do you just give them palliative care for that few times, so that something like that? Yeah, that's the question. Then the third question is, patients with hypertension, okay, they have an existing hypertension, and you have established they have increased ICP. Do you still give mannitol as your first choice of decreasing the ICP before after the neuroconservative pressures, of course? Thank you. I think that's my question.
So those are the questions, Let's start with number one, about the choice of analgesia. One, we always like giving paracetamol. Two, patient who has traumatic brain injury, most of the time they have a bleeding problem, like they might have had brain contusion, like they have those bruises in the brain, or they have epidural hematoma or subdural hematoma. And the nasty thing about NSAIDs is that they usually prevent platelet aggregation, such that if there is bleeding, they may worsen the bleeding. So especially in acute, we usually go for, we usually avoid NSAIDs. So we give paracetamol, we give tramadol usually. Some people give beta pain. Other people, like where I am right now in Eldoret, they love giving morphine. But again, as there is a very good corollary that we were given, that tramadol increases seizure threshold. So usually when you give tramadol, it's good to give it with an anticonvulsant. I don't know, Najma, if that answers your question.
Yes, Dr. Thank you.
Question number two, in terms of what to do for very low GCS. Do you want a controversial answer or a practical answer? Because there are those two types of answers.
No, the thing that you do as Dr. Yunus, or let's say your colleagues in what kind of calls do you make? The most common ones you make?
One, when patients come, the images I've shown you, those are very nice images. Patients come with nasty injuries. And as a doctor, you try not to play God. We have seen patients with GCS of 3 walking home in a few situations. Like if maybe 100 people came with GCS of 4, or 1,000 people, like 2 of them go home. And you do not know who those 2 are. And also it depends on what kind of injury have you gotten. So when we meet those kind of patients, we usually sit down with their relatives. And we tell them, these patients, GCS of 4, mortality rate is very high. Like maybe 1 in 1,000 or 5 in 1,000 is what will go home. Meaning, if 100 people get where this patient is, maybe all of them sometimes do not make it. So if the family decide that they do not want to proceed with any surgical management, that is up to them. But if the family insists, we usually operate. And then also in terms of predictors of outcome, like patient with midline shift more than 1 centimeter, that outcome is very poor. Patient who has something called, patient who has herniated, such that both of the pupils are dilated, those patients usually have nasty outcomes. Elderly patients, whatever the injury, they usually have poor outcomes. So if the patient is young, like a baby, has a lesion that when we evacuate, the patient can get better, like epidural hematoma. If you find it at GCS of 4, you operate without asking any questions. Subdural hematoma, that is more academic, because most of the time subdural hematoma, as we have been told, they have diffuse brain injury that is not related to the hematoma-related mass effect. So there is no one correct answer, but the answer is it depends on the patient, the clinical situation at that time. Patient can have GCS of 4, but this patient also has a bleeding liver injury, has a spine fracture that is at say C3, such that his diaphragm is not working, such that those polytrauma patients, you do not run. Patients who are very elderly, you do not run. But as a doctor, you cannot say until patient is brain dead, you cannot say we are not operating. But it is a discussion with the family. And with the rest of the even medical professions. Like as a doctor, as a neurosurgeon, I'll have to discuss with the right answer for us. But those ones, we always try to give them a chance. But I'm telling you, all those patients we operate, this very low GCS, they stay in ICU for 6 months, some of them, and a few of them just wake up and go home. I think those are my responses. And the last question was giving mannitol to patients with a non-hypertensive patient.
Yes.
Hello, are you there?
Yes.
So mannitol, there are contraindications. Patients who are hypotensive is not given. One, because you are trying to deplete volume. So if you are already, your blood pressure is still very low, if you are given mannitol, it makes it worse. So we usually do not give. Patients who have heart failure, we also are very cautious, because if we can diurese them so much such that they go into hypotension. Patients who have acute kidney injury, we also do not give. Other people we do not give mannitol to are people who have bleeding tendencies, because mannitol has, in high doses, can cause patients to have a bleeding tendency. So if patient already has, like you come in with an elderly man who has been on aspirin and clopidogrel because of a previous cardiomyopathy or heart disease, or had anemia or something, or you come in with a 72-year-old lady with cardiac valve prosthesis who has been on warfarin, you do not want to give mannitol, because mannitol will make the bleeding tendency worse, especially if you are planning to operate. So other than that, patients with hypertension, actually you can give mannitol. What you do not give mannitol, what you do not give in patients with very high blood pressure is hypertonic saline, which is an option for patients who cannot take mannitol. You can give mannitol, you can get 3% hypertonic saline. The doses are almost the same. You can give patients like 250 mils start, then you can give 100 for about 3 days, 100 mils 3 times a day for about 3 days. But if you are giving patient hypertonic saline, which is mostly sodium, and patient who already has increased, with patients already hypertensive, they can go into hypertensive crisis. So mannitol is actually preferred in patients with hypertension, to my understanding. I think that is all I've got. Any more questions? Any more questions?
I think there's one question
suggesting
in the chat.
Yeah, there is someone who is suggesting we can give furosemide plus mannitol. Okay, I don't know. Furosemide we give to patients with chronic subdural hematoma. We also give in ICU, but it's not a usual thing. But and furosemide, it doesn't change that much. Any more questions? I think then we call it.
I think there's no more questions, Dr. Yunus. I'd like to thank you so much for tuning in and taking us through the session. It was an interesting one, and we surely learned a lot. May Allah bless you immensely for your effort. I'd also want to thank